All right, we'll go ahead and get started. Welcome, everyone. My name is Matt Buman. I'm a professor and director here in the College of Health Solutions at ASU. I'd like to thank you for joining our Health Talks webinar brought to you by the College of Health Solutions here at ASU. Our college works to address the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. These health talks are just one way that we serve the community with timely and relevant educational information that also provides continuing education credit at no cost. So we have a few housekeeping items before we get started. First, this session is being recorded, and it will also be posted on our website, asuhealthtalks.com. After all of the panelists have presented, I'm going to moderate a Q&A session. So please submit your questions through the Q&A feature and not the chat box, and we'll be addressing them after all the panelists have spoken. Finally, after the talk, you're going to receive a brief survey asking for your input about today's webinar. If you are requesting continuing education credits, this must be completed in order to receive the credit. If you didn't apply for the CEUs, we'd still very much value and appreciate your feedback so we can continue to improve the Health Talks series. All right, let's go ahead and get started. Today's topic is 24/7 care anywhere, harnessing the power of mobile devices and wearables. There's three speakers. I'm actually the first speaker, so I'll introduce myself when I begin my talk in just a moment. Our second speaker is Hassan Ghasemzadeh. He is an associate professor of biomedical informatics here at ASU in the College of Health Solutions. Before coming to ASU in 2021, he was a computer science faculty at Washington State. He's an expert in machine learning design for mobile health systems with applications in chronic disease prevention and management. He's also an associate editor of IEEE Journal of Biomedical and Health Informatics, and his work has been recognized by numerous awards, including the National Science Foundation Career Award. And then our third and final panelist will be Adela Grando. Dr. Grando is an associate professor in biomedical informatics and an adjunct assistant professor at the Mayo Clinic. Her areas of expertise are health information technology, patient-centered technology, and mobile health. An important focus of her research are on Latinx populations and individuals with behavioral health conditions. So we're very fortunate to have both of these health experts with us today as we explore this topic of harnessing mobile devices and wearables. So I'm going to go ahead and begin my presentation. This is just the agenda for each of our topics that I've sort of already queued up for us. So I'm going to be talking about using smartphones and wearable devices and other ubiquitous technology and how we can harness it for personalized lifestyle medicine. And I will first start with giving you some examples of some ways that we've done this over the last few years in terms of leveraging these technologies to support healthy lifestyles. And then I will try to set the stage for kind of where we can use these technologies in the future to advance this area and some of my thoughts in that area. So by way of introduction of myself, professor here in the College of Health Solutions, my overarching research trajectory is on understanding the dynamic interplay of sleep, sedentary and more active behaviors, these lifestyle behaviors, and how collectively these behaviors can be harnessed for health promotion and disease prevention. I focus in multiple areas, again, as you can see here, in terms of validation of wearable devices and making sure that the both commercial and research grade devices that are available to us are well validated and can measure these 24-hour behaviors. Also focused on smartphone apps that actually use these devices to deliver interventions, and that's what I'm going to spend the majority of my talk today covering. And then finally, in maybe another day, we can talk about some of my work in workplace interventions to reduce sitting and increase light intensity physical activity. So I just wanted to start by, because we're going to use that term wearable technology a lot. And I know there's a lot, Hassan and Adela will mention a few others, but wanted to tell you a little bit about some of the devices we use in our research in intervention. So I think you're all familiar with the Fitbit devices. So we use these devices to measure things like physical activity and sleep, of course. And importantly, because this device is so wearable and people are so used to seeing it, that this is something that has the advantage of, we can expect people to wear this device 24/7 for very long periods of time. And most people are very pleased to wear it. It's a device that we continuously integrate into our research, but also into practice. In other words, the data that comes from it, we actually think of that as an intervention in and of itself that is useful, that we can harness and leverage to help people monitor their behaviors. Separate from that, we use another device, and there's a lot of devices out there that can be used, but these last two devices are research grade devices. So these are devices you typically wouldn't see out in the public, but we use them in research settings to be able to have a little bit more flexibility and more accuracy in how we measure, in this case, both sleep and physical activity. So this Genie Active device is worn on the wrist. In addition to measuring movement, so sleep and physical activity, it also measures temperature and light as well. And just to highlight the differences in these sensors, this Genie Active measures samples anywhere between 40 and 100 times a second. And does that on multiple dimensions over multiple days and weeks. So you can imagine the kinds of data that would come from this is just massive. And so it's a little different than Fitbit. The third device I'll mention is the Active Pal. So this is, again, a research grade device, not something you'd see out in the general public, but this device actually goes on the thigh, and that sounds overwhelming, but it actually, people actually don't mind wearing it there. And it is the thing that it gets very well that other devices don't is posture. So a Fitbit will, of course, give you how much movement you're making, but it won't tell you whether you're doing that sitting versus standing versus moving. And this ActiPal, due to its location and the way that it's developed, is highly accurate at measuring posture. So I just wanted to kind of mention some of these devices since I'll be referring to them as we move forward. So the first app I want to talk to you about is an app that we developed probably 7 years ago now called BeWell24. So what we did is rather than sort of reinventing the wheel, what we did is we took what we know about behavior change in 24-hour behaviors, sleep, sedentary behavior, sitting, and physical activity, and we tried to take the most evidence-based approaches we could find and put them into an app format so that these were accessible and usable by individuals. And you can see we also have a dietary component also added. And what was really important, what you see here, is this sort of dashboard-like views that give real-time feedback to the participant, real-time continuous self-monitoring of these behaviors. And I should note that these data that these users are seeing is being pulled directly from a Fitbit device that's integrated into the system. So they're getting real-time data just as they would in a Fitbit app, but being done in an evidence-based, scientific, behaviorally scientific approach. And in this study, we did this alongside my collaborator, Dr. Peter Reven from the Phoenix VA. We conducted this study and we're testing to see which of these components of the intervention would work in individuals at risk for diabetes, veterans at risk for diabetes delivered through primary care. And our results, we found that those who received that sleep component I just showed you actually reduced their, increased their sleep efficiency, or how a sleep quality measure, by 7%. Those who received that sitting component reduced their sitting time by about 12%, which equated to about 47 minutes per day. And again, that's measured by that ActiPal that measures posture really well. Those who received the physical activity component increased their physical activity by 11 minutes per day, which doesn't seem like a lot, but these were really inactive people, so it's actually quite a big increase for them. Interestingly, those who received 2 or more of those components together, we had a very interesting design here, actually reduced their fasting glucose. This was a pre-diabetic group by 12.3% relative to those who received only 1 or none of the conditions. So showing some evidence that when you pair these components together, you actually will get greater benefit on the cardiometabolic risk side. I also wanted to point out that another thing that we did here that we were interested in is how do we get this information back to providers? How do we communicate these data? And I think that Adela and Hassan as well will mention this a little bit as well. This is just a quick view. If you're familiar with the VA healthcare system, EHR system, it's not pretty. But this is an example of some of the testing that we did to take the Fitbit data that we collected, put it into a format that's easily understandable by providers, and to display that back to them through the EHR system. And so you can see we and using feedback from clinicians, we developed this to be very clear to the patient, or excuse me, to the provider about how their patient was doing, and to give them some tips on how to respond. The next thing I wanted to mention was another study we did at Mayo Clinic called Sleepwell 24. So this was an app to increase CPAP adherence among individuals newly prescribed CPAP. In this case, we did indeed link a Fitbit, as we did with the previous study, but we also linked in a common CPAP device. And again, we're using a dashboard-like approach, providing real-time feedback to participants about their CPAP usage, as well as in other data around CPAP events and leakage, important indicators that are important for adherence within this. We're still looking at our results, so I don't have any results to share with you at the moment, but I did want to mention this is sort of another way to look at give feedback to providers. In this case, we didn't go through the EHR system, but instead we developed what we call a Show My Provider screen. So this screen was within the app for the patient, but it was specifically designed for the provider in mind. So the patient can click on the Show My Provider button and then turn that phone around and show it right to their provider. And this gives in this case, the sleep medicine specialist provider, the specific information that they're looking to help them make better clinical decisions. And so you can see an example of what this, and again, all of this is pulled from the Fitbit, as well as other sensors within the phone and patient-reported data to be able to give providers a quick look at how their patient is doing. I briefly wanted to mention a study we have ongoing. So this is another use of technology. Here, we're actually, ironically, using technology to reduce the use of technology. In this case, to reduce sedentary screen time in adults. Essentially, think Netflix and other streaming services. How do we get adults to spend less time? In this case, we have an app that gives real-time feedback because we've connected through smart home features like a smart plug and a Raspberry Pi in-home network device to be able to, in real time, measure screen time, give prompts back to participants. So I just wanted to mention this sort of another example. And of course, we're giving evidence-based behavioral strategies to reduce screen time, helping people set goals and limits around their screen time, giving them feedback when they're binge watching to help them remember to stop, those types of things. So again, trying to use evidence-based behavioral science to help address some of these issues. So I wanted to give you a background of some of the things that we've been doing, and most of what I've shown you, with some small exceptions, have been relatively static. In other words, these are interventions that we deliver in a relatively standardized way, and individuals experience the intervention very similarly. There's some exceptions. We've done some small modifications and adaptations to some of the messaging and prompting that we give participants. But we're in the age of adaptation and precision health now. And when we think about precision health, often the first thing that comes to mind is thinking about genetics and other biological factors to adapt interventions and treatments based upon those. But what we're trying to think about more broadly is enhance that to not just think about genes and epigenetics, but also to think about how can we use these mobile and wearable technologies? How can we understand better social behavioral determinants and environments, location where people are, so that we can deliver more personalized and tailored approaches? So more than just genetics and biology, but how can we take someone's behavioral profile and the patterns of what they're doing and help predict and give them the right intervention? So the way I like to describe it is that we're looking to try to deliver the right intervention to the right person at the right time, accounting for their biology, their behavior, and the environments that they live in, and then knowing that this is going to adapt over time. So this is where we're headed. I want to give you a couple of examples from other people's work that I think is really interesting to think about here. The first is what my former mentor back at Stanford, Abby King, would always call that the witch's conundrum, right? We know that these things work. We know that certain treatments work, but then we immediately ask, well, what works for whom, under what conditions? It's sort of a which person, which condition, et cetera. So this witch's conundrum of nothing works for everyone. And of course, even within ourselves, things will work differently. So when we think about how do you adapt interventions, we think about how do you sequence intervention options, like the type of intervention, the intensity of it, how it's being delivered, and how do you sequence that over time within a given individual. So the intervention I need today might not be the same intervention I need in a week from now or in 2 months from now. So how do we build interventions that actually change with the individual? I'll mention one of the specific using technology types of interventions that fits into this adaptive category are called just-in-time adaptive interventions. So these actually leverage mobile and wireless technologies to rapidly adapt intervention approaches. So we can imagine taking someone's physical activity level captured by Fitbit and what has happened over the last 2 hours or 6 hours or 5 days, and actually decide how to prompt that individual based upon that information to give them an updated intervention that's really more relevant to them. So you can also use things like how people are feeling or their cravings. If you think about a dietary intervention, you might want to intervene in a certain way if you know that they're having a craving, or a smoking intervention, if they're feeling stressed, you might want to intervene in a certain way. So knowing that, or a physical location might also prompt us to deliver the intervention in a slightly different way. One of the kinds of trials that is often used for this is something called a SMART trial, or a sequential multiple assignment randomized trial. So this is a sequence of decisions about treatment that is being tested. So essentially you're testing a set of intervention options, and then you use something called a tailoring variable to indicate when that intervention changes. Let me give you an example. Susan Murphy is the person that really at Harvard that really sort of like championed this approach. Let me give you the example. So this is a weight loss intervention in African-American adolescents. And in this case, the first thing that they randomized on was, will these adolescents be treated in the provider's office or would they be treated at home, right? And then they treat them for weight loss over 3 months using the same approach. And then this is where things get interesting with the SMART design. They then ask the question at 3 months, did they lose weight? And they have a criteria for what that means. Did they lose weight? Did they respond, essentially? And in this case, if they did respond, then they continue on to basically maintain that same intervention. If they didn't respond, they now, that the group that had the treatment in the provider's office is now re-randomized to home-based skill instruction, so move to the home, or home-based contingency management, which is another approach. So they're re-randomized. Essentially, they're saying, okay, this group, it didn't work for that group, so let's try something else. Let's randomize into 2 other things. And the same is true for the group that was treated at home. So you actually have a built-in adaptation here, and you can actually test whether these adaptations work. For those of you who are in clinical work, you can recognize this as a stepped care model. But ultimately, it's testing this within the context of a trial. Another example is sequential full factorial designs or micro-randomized trials. In this case, we actually randomize within individuals. So this is very common in technology interventions today. Think of a prompt. You might decide when to send a given prompt, and the timing of that is really important. So within a person, you would randomize multiple times over the course of days or weeks or months, and you could actually test to see whether that prompt works. Let me give you an example from Dr. Klackner here, who's a colleague of mine. So he was sending prompts to remind people to be physically active, and he modified what type of message, what time of day that message would be sent. Would it be on a weekday or a weekend? What was the weather like when they send those messages? And where was the person when they sent the message, at home or at work? And ultimately, he randomized these different messages to be sent to individuals to make sure that they were contextually appropriate. And what he found is that when the context of the prompt was sent matched their actual context, so when there was a better fit, they were actually 14% more effective. So here it's starting to get an adaptation to say, we know with evidence that when we deliver this intervention, when we deliver this prompt at this time, under this condition, we actually will see a better effect. And I would also argue that it also is better engagement. So people are more likely to engage in the intervention when we're sending them things at the time they want to receive them. Okay, I will now pass this over. Thank you so much. I see there's some questions we can address later, but I'll pass this over to Hassan.
Well, thank you very much, Matt. This was a nice transition because I'm going to be talking about AI and machine learning and how these technologies can be used to design more adaptive and personalized intervention in an automated and data-driven way. So what I'm going to do, I'm going to talk a little bit about what machine learning is, and I'm going to talk about the applications of AI and machine learning in activity prediction, diet recommendation, and glucose prediction. And these are some of the basic building blocks for designing automated, adaptive, and personalized intervention using machine learning. So, machine learning can be considered as an alternative to traditional programming. So in traditional programming, oftentimes what we do, we design a program. So we write a computer program that takes certain inputs and generate an output by running on a computer, right? An example is, let's say, a cardiovascular risk calculator. So input to such a system is age, gender, blood pressure, cholesterol, and other factors. And based on guidelines of American Heart Association, a computer programmer can write a program that takes these inputs and basically generate a risk factor. What is the chances that a person might have a heart attack in 10 years? So as you see here, the goal is basically to automate the process of risk calculation. What it means is that we don't have to calculate the risk manually, right? So that's the traditional programming. So in contrast, in machine learning, our goal is to automate the automation. So what does that mean? It means we're interested in actually automatically generating that program without humans actually writing the program. So therefore, in order to do that, we have what is called training data when we know inputs and outputs, as opposed to basically looking at a person's data right now and feeding that to the program. We look at input, which is basically age, gender, and cholesterol level and other factors, and also output, which is look at a person's basically life over next 10 years, right? And see if they actually had a heart attack. So that becomes our training data. Then we feed it to a machine learning framework. That machine learning framework will give us a program. And that program can be used on future data to do predictions or health assessment. So examples of machine learning techniques or models or architectures of deep learning, which are quite popular these days, that take inputs and generate one or more outputs using a neural network architecture. Another example is, for example, decision tree. When you feed your data into a decision tree, and at each decision point, you branch out to a certain subtree until you reach a leaf in this decision tree where you can actually make an inference or make a prediction or calculate an assessment. Okay, so within this context, I would like to talk about a couple of applications. One is activity prediction with application for adaptive intervention design, and this is a work with Matt. Basically, the idea is that we have these wearable devices, for example, Fitbit, that detects step counts, and we have these lifestyle intervention apps that guide a person through basically lifestyle intervention to improve their physical activity behavior. So here the goal is, can we take engagement in the app data about how engaged a person is with the app, and can we take also information about physical activity level of an individual, for example, in the past 7 days, and predict how a person's physical activity will look like tomorrow. So what is the benefit of this? Because the benefit is that once you know if a person's physical activity might not be at the level that we expect, you can intervene. So how does that intervention look like? That's another, AI, ML, machine learning type of algorithm that we need to design. But here our goal was to design this forecasting model that takes app engagement and physical activity data and predict basically future activity level. So for that, the overall idea was that we have activity data and we have user engagement data. We aggregate this data through an embedding, what is called embedding process, to acquire data for the past T or N days, let's say, and then you feed that into a model, and this will give you activity level for the next day, for example. So now the question would be, how does this kind of model look like? I don't want to get into details of that in the interest of time, but essentially here what we did, we designed a neural network approach called LSTM to do that. And this is some of the results based on BWell24 data set that you saw earlier. So with the leave one subject out analysis, we were able to predict next day basic activity goal of 8,000 steps with 89% accuracy. And we did leave one subject out because we want to know how generalizable our model is to new people for whom we have no training data in the past. And you see also mean absolute error. For example, feeding both modality, activity, and app engagement, we get about 1,700 kind of as the mean absolute error. The unit here is steps, number of steps or error that you get, your measurement or prediction for next day step counts may have. And here you see R-square values as well. So this is one example of how we can build prediction in the context of basically adaptive intervention design with kind of activity promotion. Another example is diet recommendation. So assume that a person intends to reduce their weight or calorie intake within a certain period of time. So there are a number of intervention cycles. You can look at this at individual day 1, day 2, and all that to day N or T. So on each day, we want to make food recommendations to the individual, but we want to make sure that we make smallest amount of change in a person's diet. But we want to make sure that we achieve the goal within a certain time, whether it's 1 month, whether it's three months. So the goals are set in advance. So this is inspired by theories in human psychology. So behavior change has to be small, has to be gradual, has to be consistent over time to be successful. So our algorithm makes these basically recommendation with the goal of, in this example, reducing calorie intake, but it can be applied to different outcomes, for example, glucose reduction and things of that sort. So how can we basically, how does this, how is it used in practice? This is the algorithm, we call it diet assistant. So For this algorithm to work, we need to know what food a person is taking or what is their dietary intake in general. So we know there are lots of different tools out there that can estimate dietary intake. There are wearables, there are mobile apps, and MyFitnessPal is one of them. There are computer vision-based techniques that can be used to estimate dietary intake, calorie intake, macronutrient, and all that. So the idea is that we can estimate this and build a database of a person's diet habits. And that is an important piece of information when you make recommendation. You want to make sure that your recommendations are tailored toward the person's kind of diet habit, but you make small changes in order for the person to achieve their diet goal. So this can be formulated as an optimization problem. So this is the mathematical representation of that. So as you see, we're minimizing change from one cycle I to cycle I minus 1 to I. Basically, as you make progress, you want to make sure you make smallest change in the person's diet, but the smallest change would be no change. So therefore, we don't want that to happen. So therefore, we're pushing the amount of change to be at the minimum level that is computed here, which allows us to look at the goal and how many days or cycles we have in our intervention period. Therefore, we can make sure that we achieve the goal within that time frame. And based on that, so we did some analysis with basically gathered data with 10 healthy participants to look at their diet habits, and we simulated an intervention in this case. So here you see some output of the algorithm. So this that generates, okay, what food a person basically should eat or suggested to eat on a particular day, and what is the portion size for each one of them. Of course, this needs to be represented in a better way, but this is essentially the raw output of the algorithm. And on the right here in this graph, you see how calorie intake, if the person follows the recommendation, how their calorie intake will reduce from, let's say, 3,600 here to 2,200 as a goal over time, and the reduction in other outcome, protein and sugar. So with this, I want to move on to the next topic that we have been working on recently, and that's glucose prediction, specifically hyperglycemia prediction. So we know that hyperglycemia refers to spikes in blood glucose level, and we're interested in postprandial hyperglycemia, which means hyperglycemia after eating food or after a meal. So in this case, you see that this person experienced, hyperglycemia because the threshold is, 160 milligram per deciliter, and the blood glucose exceeds that level. So why is this important? Is because long-term exposure to hyperglycemia reduces glycemic control, that increases the risk of cardiovascular disease, leads to other conditions such as cancer, reduces eyesight. We know all these bad things with long-term exposure with hyperglycemia. If we can predict that before eating a particular meal, so that there's potential for preventing that, especially if we can make that explainable. So what does that mean? It means if I can build a system that can tell me taking, let's say, or eating this chocolate bar will result in hyperglycemia, I can potentially go and if the algorithm or the system can explain to me why, I can potentially go and change that kind of behavior or make modifications. And that algorithm essentially can be used in a system like this. So you provide these, hyperglycemia versus no hyperglycemia to the person in an interpretable way. For example, in here, if you design a decision tree algorithm that can tell me that if a person's, baseline glucose level is bigger than 7.75, then no matter what they eat, of course, in this case, it's data-driven. So based on the data set that we had, the person would have experienced hyperglycemia, PPHG+. But if they don't, if they're based on glucose level at this point is basically less than or equal to 7.75, we look at the carb composition. So the algorithm will look at the carb composition of the food, and it says if it's above this threshold, then they would experience hyperglycemia. Otherwise, it's safe. Go eat that food. So that's the overall idea. So and with that, we can look at how we actually designed it with the data set. So we had a data set of 5 participants in this case, type 1 and type 2 diabetes. So you can see their demographic and the number of meals that each person took over about 20 or about 3 weeks, but the maximum of 23 days, in fact. So people were on this study from 11 days to 23 days. So you can see with this data set what we achieved. So we were able to design the decision tree model that achieved 70% accuracy with an F1 score of 81% to detect hyperglycemia. And we also looked at what are the most important factors here. And we realized that the most important factors in individual patients and even generalized model, if you look at the top 2 factors, carb then is always there. Carb amount, is here, or carb composition is one important factor, which is consistent with what we know already. But this will give us specific kind of feedback in terms of why the person will experience hypoglycemic event and those thresholds. All right. With that, I think I can give it back to Matt.
All right. So we will now transition to Dr. Adela Grando, who will be talking to us about enhancing patient engagement through an app.
Well, thank you. An important part of the development of any of these technologies requires patient engagement. Without the patient being engaged, that would affect the success of your intervention. So I wanted to talk about a specific project that I conducted with the Mayo Clinic, and that it involved a development of a diabetes app. And I did this in collaboration with my Mayo Clinic colleague, Dr. Vitika Thompson, endocrinologist at the Mayo Clinic here at Phoenix. And with her, we have been working many years on diabetes, and our studies indicated that there is a significant patient variability in diabetes self-management behavior. So patients do different things to manage their diabetes. But despite that, the interventions that are being provided to patients are the same for everyone. So one size fits all. So the motivation for our research is, can we create and implement data-driven personalized interventions? And most importantly, if we implement those interventions, can we improve diabetes self-management? So what we did, we conducted a 2-phase study. So it was a before and after intervention. So in the first phase, we recruited 15 patients with type 1 diabetes, and we asked them to use their wearable devices, insulin pump, continuous glucose monitors, as they usually do. But we added on top a mobile app that we developed. And we did that because the devices were not collecting all the data that the physicians wanted to have in order to understand the behaviors of the patient. So the patients used those devices for 4 weeks, and then we used data analytics to understand the patient's behavior and how they were doing in terms of glucose control. And, these devices, the wearables, are already providing very complete reports to the physicians, but studies say that physicians do not find them useful. They don't find them actionable. So the Mayo Clinic physicians wanted to have a simple report, 2 pages at most, that could be used for an individualized intervention, some information that they consider actionable. So that was our task, how to collapse all this huge amount of data into something actionable. So when we created these reports, then the clinicians could meet the patient for 1 hour and they could discuss the report, and they could make suggestions on things that could be improved, that could lead to improvements in glucose control. So when you develop a technology, there are two aspects that you need to take into account. The front end, which is the exposure of the technology to the user. So this would be the interfaces, the functionalities, and the back end. And I think Hassan spoke a lot on that. These are the things that you don't see as a user, all the programs that are running in the background that they convert your input into output. So I wanted to discuss a little about usability, because I think usability is key for the success of these technologies. So you want to engage as soon as possible your potential users, so they give you the opinion of the design, they give you ideas to improve it, but also it's an opportunity to learn about your user. What do they want to see in a technology like this? Sometimes as you as a researcher, you have an idea of what could be useful for the user, but he or she may have a different idea of that. So you want to be willing to change your design. And evidence says that you should be able to, with 5 or 6 participants, to achieve or at least recognize 85% of your usability issues. So you actually need a small number of participants, but you need a setting as the one I'm showing there in the picture to conduct this type of studies. So you're going to recruit your participants, you're going to ask them to perform some task in your technology, in your app, with your wearable, and you're going to audio and video record what's happening. And then that information, you're going to analyze it, and you're going to count how many usability issues occur during this task and the severity. There must be some that usually are some that are more severe than other. And based on that information, you're going to improve the design of your technology, and you will continue doing this as many usability testing as you can possibly do in order to improve the technology. And you will see over time how the usability issues reduce in frequency and severity. So we did that with our app. We actually were able to do two usability testing before we use it in the Mayo study. And we developed an app that records meal intakes, alcohol intakes, and exercise. And most importantly, the compensation techniques that patients use in order when they do these activities. Because there are a lot of apps there to record meals, alcohol intake, and exercise. But at the time we developed this app, there was no app to develop diabetes self-management behaviors. So that's why we created it. And if you look at the second screen, and I haven't had lunch yet, so I can tell you this is a very good looking pizza, and it looks like a refreshing beer. The users have to take photos of their meals and the alcohol intake, and they have to take this what they did. And we know that pizza has a high content of fat, which tends to slow down the absorption of carbs. So insulin pumps now come with a very cool new advanced feature that allows you, in case the food contains fat, to use a square bolus delivery. So they deliver bolus for an extended period to compensate for that slow absorption of carb. So clearly here it looks like our participant knew how to use that function, which is great. And also the insulin pumps recommend you how much bolus you need to take. But you as a user, you can rewrite that suggestion. In this case, that's what our user did. He chose a different bolus. So this is the kind of information that we were collecting. In terms of exercise, you can do low intensity, medium intensity, or high intensity exercise. And evidence says different things in terms of how your body reacts in terms of blood glucose, depending on the intensity of exercise. So we wanted to collect information about that, to see how the patients were compensating for that, and to see how much they knew about how their body reacts to types of exercise. So for our study, this was a pilot study. We recruited 15 participants, and you can see here, these participants were doing very well. They have an average 7% of A1C, and we know 6.5% indicates that, or more, indicates that you have diabetes. So they were doing pretty well. They were using all the wearables, and they have been using pump for at least, in average, 16 years. So they were familiar with the technology, and they were using very advanced technology that it's known to help to achieve good diabetes control. So those were our participants. Participants were already doing pretty well. And we collected all the data from them, and we built this 2-page report for the physicians, and we color-coded. So the physician could use this information to guide the intervention, the meeting with the patient, to see what things they needed to focus the most on. So let's say red would mean something that you really want to talk about. So in this case, this patient never used this advanced feature that we discussed of the insulin pump that allows you to compensate for fat. So that could be an opportunity to know, do you know about this feature? Do you know how to use it? Do you know how to account for fat in food? And we found that most of our participants did not know how to account for fat in the food and didn't know how to use that function. So that was a learning opportunity. We also look at bolusing. We discovered, for instance, that one patient has a very low basal rate set up in the insulin pump, and therefore he was compensated by constantly bolusing throughout the day. So through this intervention, they changed the basal rate for a higher target, and therefore he didn't have to bolus so often. Other thing that physicians liked very much was the photos of the food, because it helped us to understand if the patient knew how to account for carbs or fat. And they were real food that patients actually take, and not the kind of pamphlets that they use. Whereas you don't know if the patient actually eat that kind of food that comes in your pamphlet, in your educational material. Another thing that the physicians like very much is, for those days of low blood glucose, we provided all the details that we were able to provide of what happened that day, what the patient did, what they ate, they drank, or what was the exercise they did. And I was impressed that the clinicians, we have 2 different clinicians looking at this report, and they were able to very fast recognize what was going on with this patient and what thing could be changed, and they agree on that. But this was manually done by the clinicians. So if you connect this with the previous talk by Hassan, there's potential to do this with a machine learning approach. And a thing that you discovered during the process is that Mayo Clinic did not have available the educational material that we needed to educate the patient, so we have to create it. So we came up with 6 pamphlets that we developed. They were approved, and now they're used in all Mayo Clinic enterprise. So that was a good outcome that came out from this project. So phase 1 happened. We have the data. We have the one-on-one meeting with the patient. We came up with suggestions of what we think could be improved. Now the patient goes back, use the technology for 4 weeks, tries to implement those improvements, and then we collect the data again, and we see if it has been an improvement in behavior and glucose control. And yes, luckily we found improvement in outcomes. So we lost 1 patient, so we were left with 14. But we saw that 12 of those 14 patients started with stable diabetes, and in phase 1, and in phase 2 continuing to have stable diabetes. So we didn't change what was working. There were 2 patients, those patients 6 or 7, who were unstable in phase 1. And through our intervention in phase 2, they became stable. So we saw an improvement in clinical outcomes there. Of course, this is just a pilot study, but I think the trend here from all our talks is that there's promises of using the data coming from all these devices to provide individualized interventions that have the potential to improve clinical outcomes. And with that, I leave it to Matt.
Wonderful. Thank you, Adela, and thank you, Hassan, for those great talks. So we have about 10 minutes for questions. And so please use the Q&A feature to ask your questions. Or if you'd really like to, you can use the raise hand feature, and Carl will unmute you and get you out of where you are and get you answered. I'm going to start while you're preparing your questions, addressing a couple questions that were asked during my talk. So Christina Nelson asked, what's the difference between lifestyle movement and exercise? Is lifestyle movement simply a step counter? So in that study, we were actually measuring both total movement as well as what we would call moderate to vigorous physical activity, which would be something more akin to exercise. Though exercise has sort of a voluntary, volitional component, planned component to it, but essentially above a moderate intensity was where we saw some increase in moderate to vigorous physical activity. But you are correct that typically when we want to think about lifestyle movement or increasing movement outside of a typical exercise session, steps are a really great way to measure that. They have real interpretability and for the most part do a good job of capturing that. The second question was Pedro's question related to, excuse me, the second question was Pedro's question related to, does Fitbit requires the wearer to input some data? What level of compliance do you observe? In the studies I shared, compliance was really good, but keep in mind with that, they had a relatively engaging app that involved multiple components that you typically don't see in sort of a Fitbit app or any other sort of wearable device app. So we had really good compliance for anywhere from 60 days in one study out to 9 months, relatively above 90% compliance. People were still wearing their device at those time points. But of course, we can't compare that to just normal Fitbit wear or normal wearable device wear. We don't know what that's like. Those companies don't share those data with them of what their broad user populations, how much they continue wearing those devices. So I think the bottom line of that is the more engagement you have with a broader set of interventions, the likely engagement of that wearable device. The more useful that information that comes from that device becomes for the patient, the more likely they are to continue to wear it. All right, so Michelle Zimmerman asks, how do each of you see the specific areas you are focused on potentially relating to future long COVID support and or research? So Adela or Hassan, do you want to take that on?
Yeah, I'm happy to talk about patient engagement. You know, there's always an issue in mobile technology, wearable technology about the patient engagement. So COVID or any other long COVID or any other condition that extends over time, I think the balance is, you know, you have to keep bringing value to the patient so they want to use it. So you have, it goes back to that, you have to engage the potential user from the beginning. Why would you use the app? What value would it bring to me? So you have more potential for successful intervention if you involve the patient from the beginning.
Yeah, and I think, you know, from my perspective, I believe, you know, long COVID and its impact on some of these outcomes, including, you know, physical activity, diet, and comorbid conditions. I believe that's an area that requires, you know, investment in research, meaning that that may lead to new algorithms that can be used to assess these outcomes. The type of intervention that can be provided needs to be personalized to these individuals, and based on their condition and context. So this is, I believe, an area that is very important and relatively unexplored.
All right, and we'll move on to the next question. Anita, thank you so much for your kind comment. And Janet asks, can you talk about data security? Who has access to the data? Is it de-identified? Boy, that's a whole nother talk. But I can briefly say in some of the studies that we did, we treat it like a research study. And so that we're able to, data collected on the device itself is de-identified from the beginning. That being said, we integrate a commercially available device like Fitbit, so it's collecting user-generated data, and of course Fitbit sees those data, and there's large arguments about who owns their Fitbit data, but we try to inform our participants very carefully that that is happening, that indeed any data collected off their wearable does go to that company, just like if they were wearing that device outside of the context of a research study. Adela, Hassan, you have more to add to that. I presume you have much more.
Oh, exactly the same. Exactly the same in all my studies. What you said applied to my studies the same.
Yeah, similar. I think we're trying to minimize the amount of private information that we collect. For example, we don't store any kind of identifiable information, well, except if we gather location data that can be potentially private, but and nothing like name or contact information or address, nothing. We do not store that kind of in conjunction with our sensor data or outcome data. So that's a separate thing. We try to de-identify data all the time, therefore. The server is always, password protected. The transmission from our mobile devices to our server is also secure. So all of that, there are lots of kind of encoding that we perform to make sure that the data is not leaked while transmitting, and if it does, it doesn't reveal any private information. Yeah, that's what we'll do.
The final note I'd say on that is when you start moving these technologies into clinical settings, of course, you're dealing now with a whole new set of challenges related to privacy. And of course, and there's so much still to be worked out in that space. But it does add a whole nother level of complexity. I think in all three of our cases, we were able to do this outside of that because it was in the context of a research study. The next question is, are there currently any considerations for low-income patients? Would wearables be covered by insurance one day, for example? Great question.
Yeah, and if I may add, for instance, my intervention was quite sophisticated and required a lot of wearable devices, and not every patient has access to all this technology. So patients with low income, but also with some cognitive challenges, bring a new aspect to this. So I just give you an example. I thought, and now that I work a lot with patients with behavioral health conditions in the community, I'm trying to adapt my interventions to make them much simpler. And that's a need, for instance, a lot of resources on their side. So I'm using, for instance, text messages, starting with text messages. So I started very simple and I start to build complexity on top of that. But start with very simple interventions using mobile devices and see if I can change, improve clinical outcomes, and how to start to build on top of those.
Yeah, I don't have a whole lot to add to that. This is not a question I can answer, but I believe it's very important. I wish we had someone with, background in with relevant background that can answer what is the landscape on the insurance and healthcare system side of this.
And finally, I'll just add that, mobile devices and to a lesser extent, wearable sensors are becoming quite ubiquitous. Research is showing that in low-income populations, the use of smartphones is actually higher than other populations, and also higher than internet access or computer use. So the mobile devices are quite ubiquitous across levels of the economic strata. Wearables for us, and I think this is true for Hassan and Adela, trying to use more accessible devices that are lower cost, and of course cost on these are indeed coming down. And I think choosing devices wisely is important. All right, well, we are at the end of our time. We thank you all so much. We encourage you to follow the College of Health Solutions on social media, as you can see here, so that you can learn about other opportunities like this one. Our Health Talk series will continue next month with a talk on health policy in Arizona. That talk will take place on Thursday, February 16th at noon, Arizona time. And you can always find more details and registration at asuhealthtalks.com. And so thank you again and have a great rest of your day.